Cât privește domnul profesor Ferrazi și domnul profesor Spirito, li consideriamo già dei nostri dell'ospedale Monza e li ringraziamo comunque per il supporto costante che hanno dato al nostro centro. Am să vorbesc în limba română ca să păstrăm culoarea locală și pentru că e limba pe care o cunosc cel mai bine. Spitalul Monza, parte componentă a grupului italian de spitale Policlinico di Monza, a deschis în 2014, dar activitatea practică am pornit-o în 2015 și mă refer aici la Centrul de Cardiomiopatie Hipertrofică Obstructivă, centru care a devenit, din dorința de a oferi pacienților servicii cât mai bune și pentru cazuri cât mai dificile și deosebite și pentru patologii rare, cum este cardiomiopatia hipertrofică obstructivă, a devenit în scurt timp, până astăzi, cu ajutorul și cu suportul Centrului Policlinico di Monza italian, a devenit unul din top 5 centre din Europa. Și putem spune că împreună, afiliați fiind la Policlinico di Monza Italia, putem spune că suntem împreună cel mai puternic centru astăzi, pentru că beneficiem de cel mai bun expert din lume, și nu este o exagerare, pentru că sunt cunoscute performanțele domnului profesor Ferrazi, și cu suportul domnului profesor Spirito în ceea ce privește această patologie dificilă și nu chiar atât de rară pe cât ne-am dori să fie. Pentru că se pare că astăzi, având în vedere numărul de intervenții pe care noi le-am făcut în Spitalul Monza, deci într-un an și jumătate am făcut 27 de cazuri, pare puțin ca cifră pentru cineva care nu cunoaște raritatea acestei boli și dificultatea de a o corecta chirurgical, dar este un număr mare dacă ne raportăm statistic la celelalte țări care cunosc această procedură și care sunt puține. Noi, în partea de est europeană, putem spune că suntem singurul centru care facem asta astăzi. De ce? Motivele sunt multiple. Pe de o parte, pentru că patologia, pentru a fi diagnosticată, este necesar să existe un centru cu multă experiență, deci nu orice centru care face chirurgie cardiacă sau cardiovasculară poate depista boala, poate diagnostica boala, fiind o patologie greu de diagnosticat, deci ai nevoie ca centrul să aibă o puternică experiență în cardiologie, ceea ce Spitalul Monza, iarăși cu suportul Policlinicii di Monza din Italia, a reușit să o facă, să aibă. Iar pe de altă parte, pentru faptul că trebuie să îndeplinești niște cerințe pe care iarăși Spitalul Monza astăzi reușește să le îndeplinească, cerințe de expertiză, de tehnologie, de imagistică și de tratament, nu? În așa fel încât patologia să o poți diagnostica și apoi trata. Întâlnirea de astăzi este o întâlnire importantă și care recunoaște valoarea Spitalului Monza și a Centrului Medical reunit cu Policlinico di Monza din Italia. Este importantă pentru că, deși suntem puțini aici, cu toate acestea sunt 4 țări pe care le reunim în întâlnirea de astăzi. Este Italia, este Ucraina, da, reprezentată de domnii profesori pe care i-am numit mai devreme. Din Italia va intra în live streaming cu noi și profesorul Cerin, a cărei pasiune pentru această patologie și pentru cardiologie este cunoscută. Și de asemenea va intra tot în live streaming în legătură cu noi, din Moldova, de la Chișinău, doctorul Bătrânac. Sper că n-am greșit numele medicilor. În centrul nostru a fost posibil, datorită suportului domnului profesor Ferrazi, care a descoperit o tehnică nouă și a cărei tehnică și experiență a fost chiar semnalată, tehnica și modul în care a abordat chirurgical patologia cardiomiopatiei hipertrofice obstructive, a fost chiar semnalată, evidențiată într-o revistă prestigioasă americană, care a patentat, într-un fel, această metodă inovativă care reduce riscurile și despre care riscurile operației și despre care domnul profesor mai târziu o să povestească. Este o boală genetică. Se pare că din 2 cazuri, unul se transmite genetic. Deci, într-o familie al căror părinți au avut această patologie sau au murit subit, din păcate, unul dintre copii poate să aibă această patologie și să o moștenească genetic. De aceea este foarte, foarte important și poate că apelul nostru cam așa ar trebui să sune, nu neapărat către medici, dar către ceilalți pacienți care nu, sau pur și simplu către public, pentru oamenii care nu cunosc patologia și n-au auzit de ea, să știe că dacă într-o familie există un astfel de caz, copiii este bine să facă analizele genetice, lucru pe care, iarăși, centrul medical îl poate face împreună cu suportul Policlinicii din Monza, Italia. Spuneam că Spitalul Monza îndeplinește toate standardele de diagnostic și tratament, de corecție chirurgicală. Din punct de vedere tehnologic, suntem la înălțimea la care putem să rezolvăm aceste cazuri deosebit de dificile, iar cu ajutorul domnului dr. Lucian Dorobanțu, care este un prestigios medic al Spitalului Monza, am reușit să coordonăm în așa fel echipa noastră și să executăm cazuri chirurgicale chiar și în momentul în care domnul profesor Ferații nu este aici. Deci școala pe care dânsul a construit-o a creat un grup de lucru de medici în Spitalul Monza care astăzi se descurcă la fel de bine și acel număr despre care vorbeam de cazuri pot fi astăzi îndeplinite și soluționate de medicii noștri. Aș vrea din nou să mulțumesc celor care ne-au dat suport în toți anii aceștia. Dacă astăzi suntem un centru recunoscut în România, dar și pe plan mondial, suntem datorită suportului pe care l-am avut din partea medicilor din Policlinico din Monza. O să-i las pe dânsii să vorbească mai departe și să vă dea amănunte despre cazurile medicale pe care le-au întâlnit și pe care pe dumneavoastră ca medici cu siguranță vă interesează. Vă mulțumesc frumos!
Mulțumim și noi, doamnei președinte Carmen Dragan, și o să continuăm programul. I'll speak in English because there are a lot of people who's watching us. So, thank you again. And I would like to introduce Professor Laroginetsit, who is the director of the National Cardiothoracic Amosov Center in Ukraine, the largest cardiothoracic center of Ukraine, who is performing more than 5,000 interventions per year. To present us his center, he's the director of the center, and thank you for coming, Professor. And
please, Professor.
Good afternoon, dear Mr. President, Professor Ferrazzi, and colleagues. Thank you very much for invitation me. Dr. Luciano presented me. I am director National Institute of Cardiovascular Surgery and President Association of Cardiovascular Surgeons of Ukraine. You can see in Ukraine today we have rate of mortality in the structure all mortality of our countries, causa of cardiovascular diseases is 68%. Ischemic heart diseases, we have population 8.7 million patients. Acute myocardial infarction, 57,000, and mortality is from 5 to 30%. Acute coronary syndrome around 190,000. And every year we have congenital heart diseases who burn in our country. You can see our development, cardiovascular surgery in Ukraine. We have a history 60 years. And the first time you can see per year we perform 120 operations with rate of mortality 12%. From 1917 to 1980 years, we perform around 2,000 operations per year, but rate of mortality around 14%. And the last 10 years, we perform around 20,000 or around, and with rate of mortality around 1.5%. In Ukraine, we have 38 cardiovascular centers who perform operation, and 28 from them perform cardiovascular full cardiovascular operation with bypass. Spectrum of cardiovascular intervention and operation in our institute is ischemic heart disease, acquired heart disease, very big experience about infective endocarditis. I show you pathology of aorta, congenital heart disease, arrhythmias, myocardial pathology, and the next new direction together with Professor Ferrazzi, obstructive hypertrophic cardiomyopathy. In our country, we don't perform heart transplantation. About our rule, and I think social mention is impossible for perform some transplantation, but our cardiac surgeon is ready for perform this operation. We have people who had study about perform heart transplant. The last year in Ukraine, all centers perform 27,000 cases percutaneous interventions and 18,000 open heart surgery. You can see this is around 13% from the main. It's nothing. You can, in this slide, you will see quantity of cardiovascular operation per million citizen. 200 per million in Ukraine, 569 in European Union, in Australia 786 per million, and you can see in United States 1,200 per million. What is this National Amosov Institute of Cardiovascular Surgery? We have 60 years experience. We have during this 60 years 200 6,000 operations. It's not intervention, it's open heart surgery operation. It's very big experience. We are leader for cardiac surgery science in our country and practice. We perform most complex cardiac patients in Ukraine. We organized 38 centers and we are unique scientific practical potential of national medicine. We have 3 members of National Academy of Sciences of Medical of Ukraine. We have 24 doctors of medicine in our institute and 7 professors from them. We have 52 people who take a degree PhD doctor. It's here you will see our dynamic from number of procedure is green. In 1980 to 1990, we performed around 2,000 operations with rate of mortality. You can see 20% to 13 to 10%. The last 10 years, we perform around 5,000 operations per year, and you can see red line is rate of mortality is around 1.3, 1.4 for these 5,000 operations. What is we perform? We perform per day 15 cardiac surgeries, 15 invasive procedure, 4 urgent cardiac surgery and 2 pediatric cardiac surgery. This per day around 35 cases. And per year we perform around 40,000 consultation outpatient in polyclinic. Around 5,000 operation and 3,000 cardiac invasive procedure. This per year. What is the capacity of our institute? Off-pump coronary artery. Today I talk with some doctor from U center. He performed off-pump surgery too during 20 years. We have our experiences around 10,000 operations with rate of mortality 0.5. The last year we have 700 operations with rate of mortality 0.4. Another direction, pathology of the aorta, including acute dissection aneurysm of aorta. We have the last 5 years experience about more than 1,200 operations with rate of mortality 2.7, including around 350 acute dissection aneurysm with rate of mortality 3.3. Another direction, unique experience, around 4,000 operations, patient with infective endocarditis. Rate of mortality in this group is 2.2%. We have unique technology, hyperthermia. During bypass, we used hyperthermia. Patients take temperature around 39.5 during 30 minutes. And after then, we perform operation. We have experienced around 35,000 for congenital heart disease. Our center perform all kind of operation without heart transplantation in child, including hypoplastic left heart syndrome, transposition grade artery, and other. Our team for congenital heart surgery decreased rate of mortality from 30 years from 27% to 1.5 per hour day. We have unique experience endovascular. The first endovascular operation for treatment congenital heart surgery we performed in 1984 is balloon dilatation pulmonary stenosis. And now we perform heart operation is classical surgery and 50% is endovascular. We closed VSD, ISD, PDA. We make stents to correction of the aorta and too many cases. We have very big experience about heart tumors like myxoma. During 17 years with zero mortality. We have a very good, big experience for cardiomyopathy, surgical treatment and dilatation cardiomyopathy, and for hypertrophic cardiomyopathy will be talk my colleague, Dr. Rudenko. New scientific practical topics in our institute: obstetric cardiology and cardiac surgery. We have experience about 700 patients, pregnancy women who had some or acquired heart disease or congenital heart diseases. And before organized this direction, patients going between obstetric gynecologists and cardiologists or cardiac surgeon. We perform around 60 operations during last 3 years in pregnancy women with aortic diseases, with congenital heart diseases, and child is alive in all cases. Urgent and emergency cardiac surgery, mini-invasive surgery. Now we working with some group cardiologists and cardiac surgeon about fetal cardiac surgery. And we are ready for heart transplantation. We working in biomedical engineering. And last 2 or 1.5 years, we working together with group professors Ferrazzi about obstructive hypertrophic cardiomyopathy. Obstetric cardiology. I told you about this, and thank you very much for giving me time for this lecture. I am very happy in your hospital. Today we have with my colleague round, and your hospital is the best hospital on Europe, and for my opinion it's very good practical job. It's not just cardiac surgery and cardiology. You have orthopedic surgery, neurosurgery, and another directions. I think it's very good for private hospital, but we are government hospital. And we have just one direction, just one type of surgery from our government. Thank you very much. I am very happy to be here. Thanks.
So thank you very much, Professor. Let me say a comment. We have a long time collaboration with the Amosov Institute. Was very fruitful because we started probably with Professor Parenzan 20 years ago to have this change of young doctor between Amosov Institute. So you see the result is also very, very satisfying and help us to continue in this direction to change between European countries the experience and to change young people to create something that is a better world probably if we are able to mix our young people. So this thank you very much to be here and thank you for the speeching. We are really happy to see how work you perform in Kiev, so complimenti. So I have also the honor to introduce my friend Paolo Spirito. He will talking about the clinical features and indication for invasive treatment in obstructive hypertrophic cardiomyopathy. We start now to be in the hypertrophic field, so I think Dr. Spirito is one of the most important cardiologists in the world to introduce these topics. Thank you, Paolo.
Thank you very much, and good afternoon. It's a pleasure to be here with you today, and I would like first to congratulate our colleagues from Kiev for the spectacular data that they've showed in terms of number of operations that they perform a day, a year, and their results. So it's a great center. Congratulations for your work. My purpose instead is much more modest, I must say, and it's simply to introduce obstructive hypertrophic cardiomyopathy, general introduction to a subject that will be discussed in detail by the colleagues. So could I have next slide? As you all know, I think here, hypertrophic cardiomyopathy is a genetic familial disease caused by mutations in genes of the cardiac sarcomere. And next, okay. If you show me how to go ahead here. Okay, but easier from here. So this disease is also characterized by a extremely diverse presentation in terms of morphology. As you can see here, patients may have, as the patient on top left, important hypertrophy of the septum, top middle mild and localized hypertrophy of the septum, apical hypertrophy, bottom left hypertrophy on the posterior wall. So there is this heterogeneity and complexity in the morphologic presentation and also in the functional presentation. All this makes hypertrophic cardiomyopathy an extremely complex and fascinating disease. Also, the clinical course, obviously, is extremely heterogeneous. Many patients, luckily, have a favorable clinical course with no symptoms or mild symptoms and normal longevity. Other patients develop symptoms of heart failure and some die suddenly, often in the absence of previous symptoms and at a young age. If we concentrate on patients with heart failure, most of these patients have the obstructive form of hypertrophic cardiomyopathy. which is characterized by dynamic obstruction to flow that is caused by systolic anterior movement of the mitral valve against the septum. You can see here on the left an old mode recording that shows clearly this phenomenon, and on the right a two-dimensional echocardiogram that shows the same phenomenon. The outflow obstruction is identified at rest or during exercise in about 60% of patients who are evaluated at referral centers. And there are important differences between patients with outflow obstruction and patients with HCM without outflow obstruction. In most patients without outflow obstruction, the disease is not a progressive disease. We could say that as a benign presentation in many of these patients. Instead, in all patients with outflow obstruction, HCM is a progressive disease with progressive clinical deterioration. For example, this slide shows the incidence of severe heart failure symptoms in patients with and without obstruction, and as you can see, the incidence of severe heart failure in patients with obstruction is significantly higher than that of patients without obstruction. Similarly, the incidence of atrial fibrillation is significantly higher than in patients with obstruction than in patients without obstruction. And this is because the left atrium shows progressive dilatation in patients with outflow obstruction. And inevitably, also prognosis is more unfavorable in patients with obstruction. Patients with obstruction have a higher mortality, HCM-related mortality, than patients without obstruction. So what are the causes of this difference, of this progression of the disease in patients with obstructive hypertrophic cardiomyopathy? The systolic obstruction to outflow will reduce stroke volume and increase left ventricular filling pressure is one. The important mitral valve regurgitation, which is usually associated with outflow obstruction, is another cause of progression, and then the left atrial dilatation with development of atrial fibrillation. So which is the medical treatment for these patients? Pharmacologic treatment in patients with obstruction relies on beta blockers. In patients who have intolerance to beta blockers, verapamil can be used, but should be used at low dosages and with caution at the beginning, because verapamil may decrease peripheral resistance and therefore increase the gradient. In patients with in progression to heart failure symptoms, important heart failure symptoms, low dose diuretics may be added to beta blockers. However, there is no evidence that medications, including beta blockers, reduce outflow obstruction at rest or increase survival in patients with hypertrophic cardiomyopathy. Therefore, pharmacologic treatment is indicated in patients with outflow obstruction who have heart failure symptoms, or in asymptomatic patients with a high left ventricular outflow gradient. Moving to invasive treatment of patients with obstructive hypertrophic cardiomyopathy, the American guidelines say that surgical septal myectomy is the preferred treatment option for most patients with obstructive HCM and important heart failure symptoms. Why the guidelines have arrived at this conclusion? Because after 30 years of experience in the United States, mainly some in Europe, with surgical treatment of obstructive hypertrophic cardiomyopathy, the results at centers with experience in surgical treatment of obstructive hypertrophic cardiomyopathy, results show that patients after myectomy have a survival that does not differ from that of patients without obstruction. While if patients with obstruction are not operated, their clinical course, as you see, and is much worse with a reduced survival. Now, I will stop here with discussing surgery because the speakers that will follow me will, each of them will discuss surgical aspects, or most of them. So I would move to the invasive treatment that does not involve surgery. The American guidelines, again, say that alcohol septal ablation, that is the alternative to myectomy, to surgical myectomy, is preferred in patients in whom surgery is contraindicated or considered at high risk, particularly if they are elderly patients. Why should alcohol septal ablation be confined to HCM patients with important contraindication to surgery, or only elderly patients? But there are a number of reasons for this that I will discuss with you. As you know, alcohol septal ablation is based on injection of alcohol in the first septal branch, as you can see on the left, of the anterior descending coronary artery. Those three arrows show the septal branch, and after injection of alcohol, the septal branch is occluded, as you can see on the right. This causes a myocardial infarction with scarring and possibly septal thinning of the septum and reduction of the gradient. At least this is the hope in proceeding in procedure. Here you see, for example, a successful alcohol septal ablation with thinning of the basal septum. This is a patient in whom we performed alcohol septal ablation many years ago, more than 15 years ago, because after about 20-25 septal ablations, we realized that we were not satisfied with the technique for a number of reasons. In this patient, things went well because you can see the basal septum is thinned, and so the area of contact between mitral valve and septum is abolished, and there was then no gradient. But there are important problems with alcohol septal ablation. Here you see the potential. These are examples of the potential inappropriate distribution of alcohol during septal ablation in patients with hypertrophic cardiomyopathy. This is a slide that was given to me by Hubert Sigevis, who is the European expert in alcohol septal ablation, and he is very honest when he discusses the limitations of the technique. This is what the contrast you see is contrast agent, is not alcohol. So that is injected before injecting the alcohol to make sure that the alcohol goes to the right place. But you see here on the left that the contrast agent in the top and bottom goes to the papillary muscle. Therefore, should we have injected alcohol, we would have caused an acute mitral valve regurgitation with severe, severe heart failure and possibly death of the patient. The 4 cases in the center show that the contrast agent and then the alcohol would distribute to the posterolateral free wall, and so alcohol would cause an extensive infarction of the posterolateral free wall that doesn't have anything to do with the obstruction and would destroy the function of the ventricle. And the extreme right, you see instead the contrast agent that goes to this to the papillary muscle of the right ventricle. And why this may happen? Because we should keep in mind that the septum is the most vascularized area of the ventricle, because the blood arrives to the septum from both septal branches of the anterior descending and branches from the posterior descending artery, and these branches form a net. So when you inject the alcohol, it's very difficult to predict where the alcohol will go. It's like when it rains, that water goes where it wants. So this is the case, same case with alcohol in alcohol septal ablation. In many patients, the alcohol goes where it wants. This is a case of not effective septal ablation. You see that the alcohol thinned the medium septum, while the contact between mitral valvular septum was at the level of the basal septum, therefore was ineffective. This is a schematic representation of the different effects of surgical myectomy and alcohol septal ablation, very different on the ventricle. This was published by the Mayo Clinic years ago. You see on the left, in septal myectomy, a portion of the septum is excised and leaves a regular area with enlargement of the outflow tract. Instead, for alcohol septal ablation, it has, I must say, a destructive effect on the septum, because I've never seen an alcohol septal ablation in which the alcohol would not go both on the right side and left side of the septum. You see here from the same paper from the Mayo Clinic, magnetic resonance recorded in patients with septal myectomy before and after the procedure. On the left, the MRI is before the procedure. In the middle, you can see that the area of the myectomy with enlargement at the top, with enlargement of the outflow tract, and on the right you see the gadolinium that does not localize in the area of the myectomy, because the myectomy doesn't create a scar. These are instead 3 patients with alcohol septal ablation, again from the same paper from the Mayo Clinic. And you see on the left before ablation, and on the right the gadolinium that shows the area of scar, and you see that the area of myocardial infarction and scar is widely diffused in the septum, and also in areas different from the septum. So scar can be arrhythmogenic. We have learned that from coronary artery disease, and hypertrophic cardiomyopathy is itself an arrhythmogenic disease. Therefore, these scars may favor ventricular tachyarrhythmias. This is a case that was reported in New England Journal of Medicine many years ago, after a few years of alcohol septal ablation, by colleagues that wanted to inform cardiologists of the potential arrhythmic effects of alcohol septal ablation. This tachyarrhythmia occurred 16 days after septal ablation. Then, next slide is the one before the last, and I just put it together today because this is the patient that is in program for myectomy here at the hospital tomorrow. This patient, unfortunately, had alcohol septal ablation years ago, in 2007, and you can see the disruptive, this is an MRI with gadolinium, delayed gadolinium enhancement, and you can see the white areas that show the extensive scar on the septum, lateral free wall, posterior free wall. So this, the alcohol septal ablation is also a procedure that increases substantially the risk of myectomy in patients that then, because alcohol ablation has failed, need to be treated surgically. So this is alarming. This patient will go to surgery tomorrow. So in conclusion, obstructive HCM, as we have seen, is a progressive disease associated with heart failure, atrial fibrillation, and reduced survival. In patients with obstructive HCM and important heart failure symptoms, as the American guidelines say, surgical myectomy is the treatment of first choice. And again, following our colleagues from across the Atlantic, this experience and this attitude is also shared by the European group. In elderly patients or patients with contraindication to surgery who have severe failure symptoms, alcohol septal ablation should be considered as an alternative to septal myectomy, but only in those patients, not in the young patient with obstruction, or as it often happens now in Europe. Thank you for your attention.
Thank you, Professor Spirito, for your excellent presentation. It's really an honor to have you here. And thank you very much for your collaboration and for the success of our center. It's due to your activity also. I just want to make a short comment that here in Romania, before the surgery appears and before we have this program of HOCM, the alcohol septal ablation saved a lot of lives. So, but now we have the opportunity to do the right things in patients. Thank you again, and thank you for your help, because our center is what is it now, mainly because of you and Professor Ferrazzi. Thank you. And I want to ask Dr. Cherin from Novara. Hello,
yes.
Dr. Cherin.
I'm here.
And
did you hear me?
Are you?
Hello.
Hello.
Good afternoon.
Good afternoon. It's a pleasure for me to introduce Dr. Cherin from Clinica San Gaudenzio from Novara, Italy, who's going to present the perioperative echography in HOCM Center. He's
but
also
not,
our scientific director here. So,
hi everybody. I'm here with Dr. Diana. It's a pleasure.
Hello, Dr. Diana.
Hello.
Hello.
Ciao Marco. Ciao. Ciao Giorgio.
Hi everybody. I'm here.
Ciao Marco.
Hey. Good afternoon. Lucian and everybody there, Dr. Ferrazzi and the other professor. Hello, can you hear me?
Yeah, very well.
Yes, I
Perfect. So we are following the Congress is extremely interesting because HOCM is a very diffuse pathology, is underestimated in the population. You know that you are improving the diagnosis and also the treatment. So the best regards for you and for the Congress that is going on very well. I pass you, Dr. Cherin, for the presentation. Bye-bye to everybody.
Thank you, Marco.
Hello, everybody. Good afternoon. It's a pleasure to be here to share with you our experience. I want to give a special salute to our colleagues from Kiev, from Tbilisi. Добрый день, дорогие товарищи, добро пожаловать, дорогие товарищи, дорогие друзья, в Киеве, в Тбилиси, в Кишинев. And let me share with you our experience in hypertrophic cardiomyopathy. And first of all, I will start with the role of echocardiography. The echocardiography, as you know, is doing the diagnosis of the disease. We may have surgical planning, and also we can assess the result of the surgery by doing either transthoracic and transesophageal echocardiography, combining this information with magnetic resonance with operating room data. It's not the case to do the definition. I want only to underline the diagnosis in hypertrophic cardiomyopathy. As you can see in this image, it's enough, it's a must to have at least 50 millimeters of thickness to have the diagnosis. This hypertrophy of the left ventricle, as we all know, may produce obstruction and systolic anterior motion and the mitral regurgitation and acceleration of the blood into the left ventricular outflow tract. And this is typical gradient of dynamic gradient of hypertrophic cardiomyopathy. The first message is please do not confound, please do not forget that this is very different from the obstacle, the aortic stenosis, and I will show you later on the case, I close it, the case with two kind of gradient, dynamic and obstacle fixed gradient. The reality, the second message, in the real world, 1/3 of patients may have obstruction, gradient at rest, but we must remember and we must know, we must respect the guidelines and the experience of the dedicated center to perform stress echocardiography or pharmacological test to discover another 1/3 of patients. And it's very, very important, as Professor Spirito told us, to identify the patient to obstruction. As you can see, what means obstruction in the second NIHA class, comparing with the patient with no obstruction as regard mortality, advanced heart failure, or stroke, in this very nice article from Maron, published in New England Journal 2003. So I will divide my presentation in three aspects: the anatomy of the anatomical aspect of the anatomical types of hypertrophic cardiomyopathy, the functional diagnosis assessing of the pulmonary pressure, ejection fraction, but first of all of the gradient, and some information regarding the diagnostic. We know that the patient with severe hypertrophy are candidate for operating room, so it's enough to have more than 30 millimeters, but we have to focalize our attention in this kind of patient where the hypertrophy is not so severe, and I will focus my presentation later on some slides regarding this kind of patient. This is another type of anatomical definition, diagnosis in hypertrophic cardiomyopathy. As you can see, this is apical hypertrophic cardiomyopathy. As you can see by resonance and by echocardiography, the hypertrophy is in the middle part, in the near to the apex. The inflow tract and the outflow tract of this patient are free. There is no obstruction at this level. But if you will be careful and you will check very carefully this patient, we may have gradient nearby to the apex where it's possible to have a small cavity. Look at the magnetic resonance, and the echocardiographer must be very careful assessing carefully the apex of this patient where it's possible to have an apical aneurysm, to develop thrombus, so the patient must receive a warfarin anticoagulation. So what about the apical hypertrophic cardiomyopathy? There are few experience. Usually the patient must be in medical therapy. As regards the surgery, there is no consensus. Maybe later on we'll discuss. Ferrazzi is an expert in this one. So some surgeons prefer to open the apex, some others prefer to open the left atrium, some others from the aorta. So I will show you some patients with the left atrial approach. Let's judge a little bit the situation as regards the mitral valve and the role of mitral in the development of the obstruction. We all know that the kinetic energy in the left ventricular outflow tract is very, very high. That's why it's possible to have calcification here. But we know from the various studies that the kinetic energy pushing on the anterior mitral leaflet will produce a remodelation of the mitral valve, anterior and posterior leaflet, depending on how much quantity of collagen tissue and how much quantity of elastic tissue the patient has. We can have a dilation. We know from the study that the anterior and posterior, all the mitral valve is bigger than normal. These are studies from 92 and 2011. We know that the mitral valve in hypertrophic cardiomyopathy is bigger than normal. And when we have a systolic anterior motion, we have to combine more information. We know that the valve, the leaflets are bigger than normal, but we have to take into consideration the degree of the interventricular septum. Sometimes it's not so important. And also the geometry of the valve is changed, as demonstrated Professor Ferrazzi and his group. This is possible due to the suction effect of the kinetic energy. The coaptation point of the valve is usually down, more or less at this level in the inflow tract, and is moved superiorly in the left ventricular outflow tract. So the problem of hypertrophic septum and the remodeling of mitral valve, it's important in the surgical strategy because this is a young woman, 26 years old. As you can see, the hypertrophy of the septum is not very, very high. The patient is very symptomatic, presented more syncope. The S gradient is more than 50 millimeters. So the patient was operated in our center. We discussed, by the way, Professor Robert, and it's quite difficult to do a large myectomy. So Professor Dion considered that it's a good solution to enlarge the left ventricular outflow tract, as in this case, opening the left atrium, put a patch of autologous pericardium, and to, in this manner, to solve the situation. The same strategy was used in patients with huge hypertrophy. This is a young male, as you can see, with atrial fibrillation and atrial flutter. But look at the septum. It's pretty difficult to address through myectomy at this region. So look at how big, how important is the hypertrophy of the left ventricle. Look at the gradient. This is a very severe patient. Look at transesophageal. It's showing us that there is no practically left ventricular cavity. It's quite difficult to do a myectomy from the aorta from here. So that's why, in this case, some surgeon, as I told you, in this case, Professor Dion operated the patient performing the myectomy from the left atrium, doing the important and large myectomy, enlarging the left ventricular outflow tract using the pericard, and this is the result, 80–90% of preoperative and the maximum 20%. Look at the postoperative exam. It's impossible to do myectomy from the aorta here. So I think in some cases, and I know from our colleagues from Chisinau, Aurel Baternac will show you, some cases operated with this technique. But I think the most important, most challenging how to management is in the patient where we have only mild septal hypertrophy. Look, this is 1 centimeter, this is 2 centimeters. So this patient has not more than 20 millimeters of the length of septum, but the patient is very symptomatic, has more than 100 millimeters of mercury. This is a 3D echocardiography. As you can see, there is no so important hypertrophy, but we can see that some here, we can see the patient is very symptomatic. After 200 milligrams, the patient remained with high gradient, so we decided to do surgery. This is, as you can see, the left ventricular cavity is virtual one, and this is the gradient completely over the same as the gradient from the our echocardiographic assessment. So what about the intraoperative echocardiography? You can see that the septum is a little bit more hypertrophic, and this is the magnetic resonance showing more or less the same thing. And we must assess separately anterior and the posterior septum. As you can see, transesophageal is not more than 80 millimeters. And this data must be ever confronted with a magnetic resonance, which has a higher definition. And it's impossible to do nowadays surgical planning without a very good examination. So this is anterior septum. As you can see, Professor Ferrazzi is assessing how much has to be the myectomy. And the conclusion was we have to do in this kind of patient because 80 millimeters septum, there is a risk, high risk to do a perforation. So the question, before discussing with you the results, how it's possible to have so high gradient without so important hypertrophy of the heart? The answer is here, and there is a important consequence of this aspect of the mitral. We know from the experience of various centers, and Professor Ferrazzi is one of them, who demonstrated by force that there is a transformation of the cord. This is due to kinetic energy, high kinetic energy in the left ventricular outflow tract. The mitral is overturned, and this cord will become fibrotic. And at the same time, the cord belonging to the first degree, to the edge of the valve, will be slack. So this kind of patient is not enough to do only myectomy. This is one-piece myectomy as usual. Professor Ferrazzi is doing one-piece myectomy. But to enlarge the left ventricular outflow tract, it's very important to look at the cord. And this is the technique of Professor Ferrazzi, the unique one, cutting the cord from our transaortic approach. And that by the echocardiographer, the colleagues doing magnetic resonance, and also the surgeon, the operating room, must be very careful to assess A1, A2, A3 patient. So this is another and very clever solution to enlarge the left ventricular outflow tract. Look at the piece of myectomy is not so big one. This is the post-operative immediately transesophageal echocardiography. There is no mitral regurgitation. There is no sum, as you can see. Look at the discharge transthoracic. This is the rest of cord, which was cut by Professor Ferrazzi and Dr. Luciano Banzo in the operating room. This is follow-up at 1 month, a good contractility, no mitral regurgitation. The maximum gradient is 10, as comparing with more than 100 before the operation. So this is, I think, one of the most important aspects. As regards functional diagnosis, we know the patient with more than 50 millimeters must go into the operating theater. But the problem, as I told you before, you have to be very careful in this kind of patient. This is not more than 20 millimeters. This is rest echocardiography, 50 millimeters. Look at the gradient. Don't seem to be a dynamic gradient. But if you will respect the guidelines, if you will do stress echocardiography, look at the 9 minutes 90 typical gradient, so we will discover another 30% of patients, and we know look at this, this study showing that a number of patients will remain at post-exercise with the same gradient, but a very big number of them after exercise, dobutamine, Valsalva, or isoproterenol infusion will demonstrate obstruction, and we know that the patient with obstruction has this future, so they are candidate for surgical myotomy when we have obstruction. That means 50 millimeters of mercurium gradient at rest or with salva, and when the patient remain, despite of the medical therapy, they may have angina, dyspnea, or syncope. So the message that I want to share with you is that we have to consider the exercise echocardiography as a key test, which defines not only the natural history, but also the management of the patient, and should be considered as routine evaluation of all patients with hypertrophic cardiomyopathy, with or without obstruction. What means to do surgery? Professor Spirito showed us before what means to enlarge the left ventricular outflow tract. This is a very nice study published by the group of Oman in 2005. These are patients, very symptomatic patients. 90% of them were in advanced heart failure that in IHA class. They were operated for that one. And look what's happened to the patient with first or second IHA class, which was not operated. So the message is we must operate the patient. The last two slides to aspect regard differential diagnosis. I will show you this nice case, a patient 47 years old, very symptomatic, which seems to be to have all the criteria. This is SUM, as you can see. This is dynamic gradient. This is SUM. So trying to assess the degree of aortic regurgitation, we found that the patient has a 40 millimeters of mean gradient. But we have to observe that we have a complete different types of gradient. This is dynamic gradient. You know, this is a light peaking dagger-shaped gradient, and this is a fixed gradient, what means that the patient must have somewhere a physical obstacle. So let's go back to study the patient better, and it seems to have a membrane here. And in fact, operatively, we confirm that this patient has in reality subaortic membrane with aortic regurgitation due to a jet lesion, and we changed the surgical strategy. Look at the valve, aortic valve is not calcific, so the surgeon was Marco Diena decided to do moromyectomy, and this is the piece of moro, and also to the excision of the subaortic membrane to do the repair of the aortic valve at Pleasure, as you can see in this photo, and so to repair mitral, there is to have mitral regurgitation after surgery. Look at the result, post-operative result. This is aortic regurgitation, which is trivial, mild aortic regurgitation, and also we perform the reductive passive, the ascending aorta. This is the patient in 2006, and I have the possibility to check the patient again in 2014. The patient is 4th class. This is mild aortic regurgitation, so I think it's important to have a very large vision of this. The last slide regards the patient with amyloidosis. Please do not confound this kind of patient. Maybe look at the valves, because the amyloidosis will produce the thickness of the valve. And with this slide, I will finish the presentation, trying to underline the fact that we have, let's consider two kinds of patients. Patient with rest and obstruction must do surgery when the gradient remains higher than 50 in spite of the medical therapy, but we have this kind of patient, and we know that we to avoid a misdiagnosis, we must do stress echocardiography to discover the patient with obstruction and to change the future of this patient from here to operate the patient and to move the patient more or less at this risk of that. Thank you for your attention.
Thank you very much, Dr. Cherin. And
Really welcome.
it's my pleasure to introduce Dr. Dan Delano, who's going to speak about the alcohol septal ablation in HOCM.
Well, my mission is not very easy after such a good presentation of Professor Spirito. Of course, septal ablation is not an ideal, by far is not an ideal procedure, of course, but sometimes it helps, and as you said, Professor Spirito, there are some indications, however, to do such a procedure, so maybe we should know about it and to discuss about it and everything about such interventional procedure. Well, we are speaking, of course, about obstructive hypertrophic cardiomyopathy, which is characterized by in general by an asymmetric hypertrophy. As you see in this echo image is septal asymmetric hypertrophy, which generates an obstruction and gradient, and this obstruction, this hypertrophy generate a systolic anterior motion like you see in this ventriculography, and this increases actually the gradient between the LV and the aorta. Well, is it important to treat the obstruction? Of course it is, as you have heard already. This form of cardiomyopathy, the obstructive cardiomyopathy, the prognostic of this disease is much worse than the non-obstructive form of the disease. And if we relieve the gradient, if we treat the obstruction, the prognostic of the patient is going better, as you see here in the surgical procedures after surgical myectomy, relieving the gradient and the obstruction, the prognostic of the patient will be better. But what about myectomy from the cardiological point of view? You know, there are some drawbacks of the surgery in general, because you need a cardiopulmonary bypass, which can produce some neurological problems. You have some other complications from cardiac surgery, thromboembolic infections, and so on. So there is some problems about any cardiac surgery. So the interventional cardiologists thought to treat this this obstruction by provoking an acute myocardial infarction, actually by diminishing, by reducing the size of the basal septum, and so on, by producing the relieving of the gradient of the obstruction. How can we produce an infarction? Actually, we should obstruct an artery, and the first septal artery, which is the artery which irrigates the basal part of the septum, which is exactly the same part of the septum which produced the obstruction. And the first idea was to obstruct with coils, and then to obstruct with cover stents, the first septal artery. Both methods were not useful because of the very big collateralization in the septal arteries, and actually it was not useful and it's not effective. So the idea of Ulrich Siegwart was to produce the occlusion of the first septal artery by alcohol ablation. Actually, it is not only the vascular occlusion, but there is also a tissular effect of the alcohol in the septum. And what was the aim of this method was to produce the septal branch occlusion and to produce a localized infarction, which is not big in general. And this will lead to the reduction of the septal thickness and the reduction of the left ventricular outflow tract with reduction of the gradient. So actually it will produce a functional myectomy-like result. Of course, there is the problem with a scar and what you have shown about such a beautiful image of the MRI. But finally, actually, the result is like myectomy if you succeed to reduce the exact area of the muscle that produced the obstruction. The advantage, of course, as any interventional percutaneous procedure is that you don't need the cardiopulmonary bypass. It's not an operation, the hospital stay is shorter, the shorter recovery, of course. But, of course, there are some potential drawbacks, and you have heard already about some of them, that anyway, it's creating a scar there, and we don't know exactly maybe the long-term effect of, and the arrhythmic effect, potential arrhythmic effect of the scar. There is a risk of the procedure itself, risk of coronary damage. There are some technical failures. There are not some not good results, but depending on the indication and so on. The question, the main question of this procedure is which septal branch to choose and to occlude. And there is a wide variety of anatomical variation about septal branches, so it's very hard sometimes to choose the proper septal branch to occlude. And one of our studies showed that there is a wide variety and diversity of anatomy of the septal branches, with more than one big septal branch, some bifurcated septal branch, and so on. A lot of other possibilities. So in these days, we should guide our procedure with echo, with contrast echo. We need to inject Levovist inside the first, second, and which septal artery we try to find, and to see what is the area which is right near the anterior septal movement and the proper part of the septum which produces the obstruction. So if we do such a study during the procedure, the probability to find the good septal branch in order to occlude it is much bigger than otherwise. Well, what are the clinical indication? You have heard about it, that we should have a gradient more than 50 millimeter of mercury in resting or provoked gradient. And we should have some morphologic indication. Then in this part, the echocardiography is very important, because it can show us if there are some valvular mitral valve problems, papillary muscle involvement, or if there is a mid-cavitary gradient, or if there are some prolonged mitral leaflets, which are not indications for ablation. Of course, we should have a coronary angiography to see if there are some good septal branches to occlude. The procedure is not very difficult. Actually, the doctor will go inside the septal branch. In this case, you see the a big first branch, septal branch, with a coaxial balloon. You should, for instance, in this picture, you see a big septal artery which is bifurcated, and we should see which part of the artery is better to occlude. And then we go with a balloon and we check with contrast. If the contrast is not going retrograde to the other septal branches into the LAD, because it could be very dangerous. And finally, we inject the alcohol, an amount, an alcohol, depending on the degree of hypertrophy. And the result in many cases are like in this picture, the gradient is going down, or you can have the result not just immediately, but in 3 months or 6 months, because there is an effect of remodeling of the septum, which is producing a decrease in the gradient, which is not in the same day of procedure, but you can obtain it in the next several months. What are the results? The results are not bad, actually. The survival after alcohol ablation is okay. You can see here an old study. Of course, there are some complications. There is a 1-2% in hospital death in the first times when maybe the procedure was not very safe and was not associated with the echo, with contrast echo. We can need a pacemaker after the procedure, because sometimes maybe in 40-50% of cases we produce right bundle block. So it's important to see if there is such a problems. And of course there is a problem of alcohol leakage in the LAD, which could be very dangerous, and it could produce a very large infarction. You can see here, if you inject in one artery, there is a reflux of the contracts within another septal branch, and a little leakage in the LAD. So this is a contraindication, absolute contraindication of ablation. What are we doing if we have other cardiac comorbidities like coronary artery disease? We used to do first the PCI, and then to do the alcohol ablation. Of course, if there is a mitral regurgitation, we should know exactly if there is an isolated mitral disease, which is important to indicate surgery, or if only the sum, which is not quite a contraindication for ablation. There are some studies comparing myectomy and ablation, which not much difference in long-term evolution. There is much more cases with pacemakers after the ablation, which maybe is important. And my conclusions are that, of course, we should have a symptomatic patient who will indicate such a procedure, that with a septal thickness more than 16 millimeter and more than 50 millimeter mercury gradient. We should have adequately sized and accessible septal branches, absence of intrinsic abnormality of mitral valve, and of course, if we have some absolute or relative contraindication of cardiac surgery, this should be and could be a solution. Okay, thank you.
Thank you very much. Thank you. So now I have the pleasure to introduce our friend, Dr. Konstantin Rudenko from Kiev. So we have the opportunity to have Dr. Rudenko as on the international school and also many times in Monza. So it's really a big pleasure. He works a lot with our technique of in hypertrophic cardiomyopathy. So it's really a great pleasure to introduce him. Thank you, Konstantin. Thank you very much.
Dear Chairman, dear colleagues, first of all, thank you very much for introduce myself, and I'm very glad to see you here, and it's a really big honor for us to take part in this meeting. I thank you, Professor Ferrazzi, Professor Spirito, for your knowledge and skills, and thank you very much for my chief and my teacher, Professor Lazarishnis, for support of this program in our institute. It's very, very big honor for me. So, hypertrophic cardiomyopathy in our institute is a traditional one of the big direction of our institute. And first of all, we started this program more than 20 years ago, and I would like to present you historical areas in our institute, because we started to treat this pathology for like a medication therapy, medical therapy, and then electrophysiological area. We implanted DDD pacing, and then alcohol septal ablation, then surgery, and now we started from September Ferrazzi procedure, and we now have not so bad results. So 20 years ago, 15 years ago, there are a lot of controversies concerning hypertrophic cardiomyopathy, in spite of the fact that this pathology was fully described in the middle of the last century. I mean, common opinion on hypertrophic cardiomyopathy as one of the multi-stage pathology. A lot of questions about regurgitation, mitral regurgitations, and mitral valve enlargement. In that time, the aim of our non-random study was to investigate the mechanism of intracardiac hemodynamics disorders, the stage developments of hypertrophic cardiomyopathy, and to substantiate different methods of treatment and evaluate also their effectiveness. Now, our material more than 400 consecutive patients with hypertrophic cardiomyopathy. I would like to show you our group. This is group drug therapy, non-obstructive form, and group patient with obstructive form and were treated invasively. This is dual chamber pacemakers, transcoronary septal ablation, surgery, classical surgery, Moreau procedure, mitral valve replacement, and Ferrazzi procedure, 49 patients, from 1 year to 76 years. In that time, there were two big hypotheses of left ventricular outflow tract origin. First of all, the mechanism of formation of LVOT obstruction and mitral regurgitation consists in the delay of excitation of the left ventricular apical part relative to left ventricular outflow tract. And for proving this hypothesis, 101 patient underwent endocardial invasive electrophysiological study, and we measured the time interval between his potential and left ventricle apex, hypertrophy zone, and lateral wall. And we observed, as you can see, considerable differences of the left ventricular spatial activation among patients with and without the systolic pressure gradient. Most patients with high pressure gradient had later apex excitation compare left ventricular outflow tract. Patient with low systolic pressure gradient, low pressure excitation took place earlier than the activation of left ventricular outflow tract. And it's also interesting to mention that particularly all patient with the high pressure gradient had different degrees of mitral regurgitation. So it was really interesting for us in that time, because we didn't know nothing about the mechanism of mitral regurgitation and secondary heart, and heroic secondary heart in this process. For confirmation this hypothesis, we also used CARTO-XP and performed endocardial electroanatomical mapping of left ventricle. On the right side, you can see a mapping of a patient without significant systolic pressure gradient, as you can see 11, but with marked hypertrophy, 4 centimeters. Left ventricle activation comes from the apex, like a normal, at advanced left ventricle outflow tract. Of the left side, you can see mapping of a patient with significant systolic pressure gradient, 90 millimeters, but thicknesses of interventricular septum 2 centimeters. And in this patient, activations comes from septum, and left ventricle apex excitation is behind the LVOT zone respect of time. So a positive effect DDD pacing confirms that electrophysiological disorders play an important role in hypertrophic cardiomyopathy cases. And we started to implant DDD pacemaker. So we have positive effect immediately. You can see patient 60 millimeters, and then after DDD implanted, 26 millimeters hierarchium systolic pressure gradient on LVOT. But you can see after procedure and follow up on this category of patient, not so good. So, despite of our material, one of the biggest in Europe, because practically 60 DDD pacing, we not recommend implant this equipment to patient with hypertrophic cardiomyopathy. And absolutely agree with Professor Meron. In early 19th, the dual chamber pacemaker was promoted as alternative for surgery, but proved less effective than myectomy, and in randomized trials, a perceived clinical benefit represented only a placebo effect. Second hypothesis on our hypothesis on the left ventricle outflow tract obstruction is a role of mitral valve. This is some effect, you know, and we start to measure lengths of end square anterior and posterior leaflet of mitral valve. And you can see we obtained certain differences in absolute dimensions, and indices in the length of cusps and systolic pressure and systolic diameter from target group of patients without cardiac defect. And we thought that enlarged and elongated mitral valve cusps play a major role in formation of some effect and develop of systolic pressure gradient. Now we know that secondary heart really play big role in the mitral regurgitation and systolic pressure gradient appearance. So in that time, 15 years ago, 10 years ago, this is our strategies for different approaches for treatment of hypertrophic cardiomyopathy. So preclinical stage, absent systolic pressure gradient drugs, two-stage non-obstructive form, also medical treatment, and obstructive form we recommended for patient systolic pressure gradient more than 30 millimeters Hg and moderate mitral insufficiency, DDD pacing or septal ablation. And finally, we recommend in a severe patient with marked mitral insufficiency, surgery. Alcohol septal ablation. Our material more than 150 patients, and we started this project 8 years ago, but you can see the results, long-term results is not so good. And AV block more than 10%, and hospital mortality and long-term mortality let us non-recommend this procedure for a vast majority of patients with obstructive form hypertrophic cardiomyopathy. So we presented this material in Portugal, in Lisbon, on the EACT as our meeting, and published in Interactive Cardiovascular Thoracic Surgery. But now our philosophy Professor Frazzi, it's surgical myectomy, the first option for more patients. So we have big historical material, and now we would like to present and show how we develop our philosophy and our strategy concerning hypertrophic cardiomyopathy. So surgery. Before we started our project with Frazzi technique, our material was 35 patients, 20 Morocco classical procedure, 6 patients. We performed Bokeria-Borisov technique. We use non-aortic approach, but right ventricle ventriculotomy. and we didn't have good results. Combination therapy and mitral valve replacement for patients. So we unfortunately we didn't have good results. So that's why we started the program, and we started to perform operation with myectomy and secondary heart resection. And by the way, and it's very important, complications in that group of patients: acute cardiac failure, AV block, iatrogenic ventricular septum defect, you can see, and mitral insufficiency. Now we want to say that Ferrazzi procedure, a modern approach in treatment of hypertrophic cardiomyopathy. And thanks to Paolo Ferrazzi, we built our team in our institute, National Institute, and we start this program in National Institute in Ukraine. Keys to success, I suppose, is a strong preoperative planning, because now we do the same stage and the same direction in our department, in our institute. Echocardiography, intraoperative echocardiography, MRI visualization, CT scan, and teamwork. It's very, very important. I would like to show you CT scan, our experience, because not just MRI we use, but CT scan also. This is CT scan a patient with a single coronary artery with obstructive form. We performed this operation 2 months ago, and CT scan and MRI really help us to improve our results and to help for this category of patient. And our results. The present study is still in progress, because we just at the beginning of our experience, 49 patients, but short-term results very good. We fortunately we have 0 hospital mortality, just 1 AV block and 1 posterior wall damage, fortunately without death. So thickness ventricular septum dynamic is very good. And now we collect our database, and for kindly help of Professor Spirito, we would like to range our patient and probably publish this result in the next month. So our plans for future, not just about concerning this program, but in Clinica di Monza as well. Scientific cooperation, very important topic for our team, because now we have agreement between Monza clinics in Monza and in Bucharest as well. Plans to develop national center of hypertrophic cardiomyopathy treatment in Ukraine, exchange knowledge and experience. And first of all, I would like to thank Professor for your help and for your support. Thank you very much.
Thank you very much, Konstantin, for your effort to study the patient with our procedure. So the result is beautiful. So my compliment, because of a really very good result. So now we planned with the Moldavian people. There is some connection with Moldavia. Hello?
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 Hello? Hi, good afternoon.
Okay, how are you, all the team in Moldavia, in Chisinau?
Okay, very well.
So it's real a pleasure to have you in this conference. So you start to talk about your experience in surgery with, for hypertrophic cardiomyopathy.
Thank you, for Professor Ferrazzi. Good afternoon, everybody who is looking and who is hearing. We have an impression that we are in the Eurovision from different countries. You can hear and we can look each other. Thank you very much for the organizing committee for the privilege for us to sharing our modest experience in hypertrophic cardiomyopathy surgery. To be honest, 10 years ago we didn't know a lot of about surgical treatment of hypertrophic cardiomyopathy. Because mostly it was a job of interventional cardiologist, or some patients would refer it even for heart transplantation. Working in a lot of prestigious cardiothoracic and vascular centers around Europe, even we don't meet a lot of patients with hypertrophic cardiomyopathy. As I said, mostly of them was referred for heart transplantation, even in Germany or France, in England. In 2010, I have the opportunity to work a short time in the Novara centers, which is a part of Monza, Polyclinic de Monza. And thanks to Dr. Diana and to Dr. Cherin, they introduced to me a lot of information about this pathology, hypertrophic cardiomyopathy, and at that time we have also the privilege to meet Professor Robert Dion from Belgium, which has also big experience in hypertrophic cardiomyopathy. And at that time in Novara we operated with the international team, so-called patient. I had also patients, a very young woman, which our international cardiology before that they did ablation of first lateral septal branch, but he has also relapse of hypertrophic cardiomyopathy, and she has to be operated. I asked Dr. Professor Dion, and also we support with Dr. Stiena and Dr. Cherin as one of the best European echocardiographers, even in transesophageal echocardiography. And so in 2011, our first cases of hypertrophic cardiomyopathy according to Robert Dion. So that time, CS we did 33 cases, and we want to present you our results. I will give the privilege to give this talk to my colleague, Dr. Rotaro, which now is the main researcher in this field, and after that I will do some comments, our experience, and which we have learned in this time interval with some questions. Thank you.
So, dear colleagues, it's a great honor for me to introduce experience of our clinic in the field of surgical treatment of hypertrophic cardiomyopathy. I'm aware that I cannot give some more information from the pathophysiological field or anatomical field after so interesting and impressive presentation, which were presented some time ago. So I will try to go on very briefly through the classification and through the definitions. Actually, I would like to emphasize mostly the experience of our clinic. Some words about the prevalence of HOCM. It's approximately 1 to 500. As you know, in adults, it's often asymptomatic, but its estimated mortality rate is no less than 1%. So about the ethiopathogeny, so a few things about the in the general population. From the pathophysiology, I will not say words because Professor Cherin explained very carefully and very interesting mechanical part of this disease. So the process of STEM actually was showed before. It's about the condition of idiopathic hypertrophic stenosis. What I would like to emphasize is the mitral aortic angle is narrowed than normal. The second, the left ventricle is small, and the mural leaflet close before the anterior leaflet and proceeded towards the left outflow tract. For the line of the left outflow tract. So, from diagnostic, we discussed before all the most important key points. One of the most relevant in our time is actually the MRI investigation, which we used in every patient pre and post operatively. Some more pictures from this investigation. Actually, about the indications for the surgery, as it was noticed before, I would like one more time to repeat that when subaortic gradient is more than 30% millimeter of mercury, this is a major risk factor for mortality. And the occurrence of arrhythmias is relatively high. So, about the treatment, as it was told before, we got medical using beta blockers as the first line medicine in this disease. In spite of this, also there is largely used the drugs blockers of calcium. The myocardial resynchronization and interventional treatment by alcohol septal ablation, as it was presented by my colleague before. The option of treatment is clear. So, what I would like to emphasize the benefit the surgery in obstructive HOCM is just to emphasize one article from European Heart Journal where it's clearly thought that myectomy should be the preferred intervention for obstructive hypertrophic cardiomyopathy. The indications are clear. So, as Professor Batranak told before, our experience in this topic started in 2011, actually 6 years ago, when this our program of HOCM treatment started by support of the Professor Robert Dion, Professor Cherin, and Professor and Dr. Marco Diena. So the first intervention in our hospital, the septal transaortic, so the septal myectomy through the mitral valve with anterior leaflet enlargement and annuloplasty ring implantation, which is the method of Professor Dion from Brussels. So here we got a few pictures of the technique of that myectomy. I will go very briefly through them. So, and here there are some pictures from our operating room inside. Here you can see with the black arrow the portion of the interventricular septum. It's as you can see, is very hypertrophied. Here is the excision of these muscle tablets. So here we got the macroscopic result of our surgery. And finally, here you can see there is no more obstruction of the ventricular outflow tract. And below you can see also the vent. Here we discuss the method of anterior mitral leaflet enlargement. The technique also was described by Hikaru Matsuda and published in 2004. Some intraoperative pictures from our side. So here you can see the resection of the anterior leaflet of mitral valve to get a better access to the left ventricle outflow tract. Here you can see the patch from the autologous pericardium, which lead to augmentation of the anterior leaflet and avoiding SAM. Some more pictures from our OR, the post-operative result. You can see the quantity of the muscle depends from the gravity of the core. About our experience, so totally here have been operated 33 patients, female 16, male 17. The mean age of them was 52 years old. So actually, thank God we got no perioperative and the short-term post-operative mortality noticed. The selected surgical techniques in 90 cases were the Robert Dion myectomy, the marrow myectomy, and the 14 cases the technique of Robert Dion. Our complication in the post-operative period, so we got one patient with ischemic stroke and one bleeding post-operatively. The average duration of the hospitalization was about 7.1 days. The structure of valvular disease associated with HOCM in a lot of patients were mitral valve insufficiency in 10 patients, aortic valve insufficiency in 6, intra-aortic combined regurg was noticed in 8 patients, and the complex insufficiency, the complex valvular insufficiency in 5 cases. So here we can see some statistical points pre and post operatively. For sure, it's clear that we got the mean gradient decreasing it in left ventricular outflow tract after operation, which noticed a significant amelioration of the situation, hemodynamic situation of the patient. So, by the literature, the overall survival in 1, 5, and 10 years after myectomy is 96, 93, and 83%. And the survival of patients who refuse this surgery in the same years is respectively 90%, 79, and 61%. Briefly, some conclusions. The gold standard of HOCM treatment remains to be radical surgical. The surgical technique applied is selected in accordance with the indications established for each individual patient. Elective surgical treatment reverses the progression of heart failure and restoring acceptable functional capacity of life. Thank you very much.
So, thank you very much to all for hearing us. Some problems which we want to note about hypertrophic cardiomyopathy. So I think now around Europe, North Center started again to do this kind of surgery. Maybe due to the possibility to have much more good diagnosis, central to the introduction of high quality MRI diagnosis. So in our center is also the gold standard now, together with echocardiography. MRI is the standard of diagnosis. Mostly the center tried to do only one technique. So according to one developer, to one surgeon, we started to think about the individual approach, to personalized approach of each patient. If the patient is only with hypertrophic cardiomyopathy or with outflow tract obstruction, without some kind of mitral valve insufficiency, that is enough to do just a shaving of hypertrophic septum, and that's all. The patient will benefit. But a lot of patients come to us with more complex problems, like mitral valve insufficiency, and my opinion is that mitral valve and hypertrophic cardiomyopathy should be diagnosed and should be attended very carefully, because if we will not treat very good mitral valve, the results will be not enough, and some kind of relapse of obstruction will be in near future. My opinion is that our approach for every patient's personalized approach, and for every patient to find the right surgical technique. So our modest experience now, but we try to go with an algorithm. Even this subvalvular obstruction of ejection tract, it's not so easy to calculate the mean gradient, because in cases of developing of severe mitral insufficiency, gradient will not be the same, will not be the gold standard for indication for surgery. Even with small gradient, but with huge mitral regurgitation, the patient should benefit from the operation. So I would not take more any time. Thank you for involving us and also this process. And Professor Ferrati will also wait for you to see your technique and to do some cases together. Thank you. Bye.
So thank you very much, Dr. Batignac, and thank you to all the colleagues in Chisinau. It was really a pleasure to hear you and your techniques and change opinion between European people. Really a great pleasure. Thank you.
Thank you.
So now we introduce Dr. Dorombato, that is responsible in Ospedale Monza for the hypertrophic cardiomyopathy program. We collaborated with Dr. Dorombato many times. So I think again this collaboration is very fruitful. And we have done a lot of these hypertrophic patients, so we asked Dr. Dorombato talking about the treatment in Bucharest of hypertrophic cardiomyopathy.
Thank you very much, Professor Ferrazzi, and thank you again, and you and Professor Spirito for helpful advice and for help to develop the center. I will pass very quickly about my presentation because we are almost half an hour in. With the time we have a problem, but I just have some points. I want to thank all the team because it's not about a person, it's about a team, and here's the name of the team with Dr. Ticulescu, Maria Alexandrescu, Ana Fruntelată, Maria Gravu, and Paula Ferrazzi, and also we have a young student Robert who's joining us every day, so in the activity of the center. What about the experience? The experience is all about the clinical cases. It's all about the patients, everyday patients. And I want to present you a case, but I do not want to insist a lot of this patient. It's a 60 years old man with a long history of HOCM with a very typical electrocardiogram. He was in atrial fibrillation. He entered in the sinus dream after the electrical conversion. This is the echocardiography preoperative. Maybe it's working, but it's not working. The technique will help me to shorten the presentation. So, with an important mitral valve regurgitation, moderate mitral valve regurgitation, alteration of the strain. It's not working, there's no problem, because I do not want to insist very well. The stick, I don't know where it is, because we had the problem and I had to mind the stick. But what, okay, the technique is not our friend today. But this is not problem, because you think it's gonna work now? No. Okay, I will pass directly to the surgical planning, like everybody is telling you, and Professor Ferrazzi will do. We'll have a serious and very standardized surgical planning with assessed of the mitral valve apparatus and the mechanism of mitral valve obstruction. We first beginning with the, no, it's not working, but with the analyzing the mitral valve, we are now knowing that there is an authorization of the coaptation point and the increasing tenting area. These are some beautiful images and 3D echo. You have to believe me. But really, I want to pass very quick because this is the MRI imaging where we're assessing the anterior wall, the anterior septum, and the posterior septum, as well as all the anomalies of the papillary muscles, chordae tendineae, and so on in various types of images. And after this preoperative planning, the patient is in the operating room. We are performing the TEE. We are confirming the TEE with the we are confronting the TEE dates with the MRI, and we now has in our heads the planning of the operation. The planning of the operation, it will, like Professor Ferrazzi will explain, it's a one-piece myectomy. It's very important to have one piece, not to have, this is the problem, load this space, I think. And we are making an extensive myomectomy, mitral valve valvuloplasty, and resection of the fibral chordae, and this, in this case, atrial fibrillation conversion. We are making the secondary chordae of the resection of the secondary chordae, and maybe no, it's not working. This the myectomy, the one-piece myectomy, that every time should be exactly have the dimensions that we planned during the preoperative analysis. This is the post-myomectomy and post-valvuloplasty echo. At least you can see a very good coaptation point, a very nice outflow tract with no gradient, no acceleration in the flux, and no mitral valve regurgitation. You can see this. So at discharge, the patient was without significant residual gradient, with trivial residual mitral regurgitation and normal systolic function. These are the images that are not working. And 1 month, this is a patient that we are following for 2 years, so we are knowing very good that now he is practically asymptomatic and without significant gradient. The maximum gradient is 16 millimeters. This is the echo after 1 year. And now I want to share with you our experience, and I reserve 5 minutes for this. It's about an experience who started in July 2015, and the data collected are to February 2017. We operated only 24 consecutive patients with HOCM in this period, but it was a great experience. And last year, with 20 patients operated, we was on the second place in Europe, like experience, communicated data, where this is only the data that are communicated for the centers. The mean age was 41 years, and in all patients, we performed transaortic septal myectomy associated with cutting of fibrotic secondary mitral valve chordae in absence of additional surgical procedures. Preoperatively, we had 9 patients in class 2 and 15 patients in class 3. This is a mistake. It's class 3. Basal ventricular thickness ranged from 15 to 37, and the mean gradient was 103 millimeters. You see here the maximum, it was 160. And the important mitral valve regurgitation was present in more than 60% of the patients. What are the results? No hospital death within 30 days after surgery. Each of the 9 patients in class 4 pre-op, post-op had no or mild heart failure symptoms. The post-operative basal septal thickness ranged from 12 to 19. But the most important is that in more than 90% of the patients, we had no gradient in more than 30 millimeters, in more than 95%. Only in one patient who had preoperatively 160 at rest, it had 35 millimeters after the operation. And in all patients except one, there were no important mitral valve regurgitation. An average of 3 mitral valve chordaes were resected. But today, I think this average of 3 mitral valve chordae, we just changed it, because today, in today's surgery, we resected 18 mitral valve chordae, 18. It was a huge quantity of mitral valve secondary chordae. So I pass directly to conclusions. In some of the HOCM, the mechanism of obstruction is determined by the mitral valve apparatus and less by the hypertrophy. It was the case of the patient with mild hypertrophy of the septum. In such patients, the myectomy alone or alcohol septal ablation are ineffective. Transaortic ventricular septal myectomy associated with cutting of fibrotic secondary chordae substantially improved symptoms, abolished the left ventricular outflow gradient, and reduced or abolished the mitral valve regurgitation in more than 90% of the patients. And these results demonstrate that a program of septal myectomy can be initiated with satisfactory results in countries like ours, in which patients did not previously have access to this procedure. But these satisfactory results, and I will say even more than satisfactory, are due to a very good collaboration and very good professors, and thank you again. Thank you.
So you present to me?
Yes, I would like to present Professor Ferrazzi, and okay, his name is already mentioned several times in this session, and I think has now more presentations. It's the mentor of 95%, more than 95% of the surgeons here.
Is my presentation when is? I don't know where they put.
I don't know. It was less than 5 minutes, 10 minutes, I hope. I don't know where's the presentation. Tak.
See, in the desktop.
Desktop, Professor Ferrazzi, Bucharest.
It is.
Fantastic.
So, these are all disappear, Lucien. I don't know what is happening when they touch the pen. Present in this way? Yeah, but the film has not worked.
No, se fa doppio clic.
Okay. Okay, so thank you. Let me thank all people that participate in this conference. It's really a pleasure. So, in 2005, I was really astonished from this slide presented by Dr. Spirito, a huge difference between patients with who underwent myectomy and the other group of a patient with obstructive cardiomyopathy but non-operated. There's a big difference, 10 years mortality. But if you read better the paper, you can understand that the group of the patient with the myectomy were in class 3-4 and the other group in class 1-2. So this difference is particularly important not only for difference in mortality but due to the very different functional class. For this reason, we started to develop this Center for Hypertrophic Cardiomyopathy. Unfortunately, this slide cut a piece of my slide. But in 2005, around here, we started to increase our procedure. And then we arrived in the 2016 around 196 patients operated for myectomy. Of course, myectomy is an heterogeneous disease. Was Something is happening. No, they all disappear. All disappear. So I don't know something. I don't know any. Yeah.
No, it's not working.
Yeah.
It's the memory of the. It's the memory of the computer. It's overloaded.
Probably is better. Thank you. So, it's an heterogeneous disease. You see these two cases. And you see the difference in terms of contractility. And you see, this is a patient with the 34 septum, and the other patient is a relative thin septum, where the mitral valve play an important role in the determination of the obstruction. It's impossible to have the film pre and post, you know. Did you ask George? It's impossible to.
I'll ask him.
Because
I think the computer is full.
I don't know when. That to be. It's impossible to have a solution on this because you know I have the film pre and post together.
I know, but probably it was worked on Macintosh, maybe.
No, no. It was working also on the other computer upstairs. Probably the touch the key without, you know.
I don't know.
Okay.
No, if you want, I can change the slides.
Yeah, okay. Help me.
Next one?
Yeah, next one. So, for this difference within patient, we decide to divide our operation. The first part is dedicated to the muscular part, and the second part is dedicated trying to correct the abnormality of the mitral valve. So next, you see here all the patients starting in 2012 receive a myectomy extended behind the mitral valve septal contact. Usually is a shallow myectomy, and second part of operation dedicated to papillary muscle, chordae tendineae, and mitral valve leaflet. For the muscular part, we found essential tool, the magnetic resonance. You see here, we studied the patient very carefully. And first of all, we see if there is some anomalies of the papillary muscle, that is the majority of the patients have these anomalies of attachment and multiple papillary muscle. You see also in the right also important crypt exactly in the point of resection, and with 2 millimeters of wall. So it's absolutely essential to know the position of this crypt to avoid septal perforation or hematoma in the lateral wall. Yeah. The other purpose of our magnetic resonance study is to understand and to prepare the operation in terms of thickness. Our goal at the moment is to decrease the thickness of the septum around 1/3. So if you have a 21 of septum, we like to cut 0.7 centimeter, avoiding too dangerous and too extensive in terms of thickness resection that keep the patient at risk for complication. Next. The second is also to extend as more as possible distally toward the apex of the ventricle, the resection, in order that the combined action between mitral repair and muscular resection to avoid residual gradient also during effort. So, after magnetic resonance, in the day of the operation, we perform transesophageal echo and we confirm this measurement to be sure that there is no problem, and we plan definitely the operation. You see here the movie of surgical myectomy. We start, of course, in the commissure and in the nadir of the right coronary cusp. So the myectomy is done in all cases with one piece for the anterior septum and eventually a second piece for the posterior septum if indicated. You see the dissection is made, have in mind all the data from previous magnetic resonance. Okay. So in some cases we perform a posterior septum indication, particularly when the hypertrophic cardiomyopathy is associated not only in basal obstruction but also mid-ventricle obstruction. This for us is very important because if you have a gradient due to SEM, also a small gradient in the mid-ventricle could be high gradient after the operation because you decrease the afterload, so you increase the gradient in the mid part of the ventricle. Another indication in patients with elongated mitral valve. Here you have an echo. This patient have a big posterior septum. This film, no? No. And this is the movie of the posterior resection. Posterior septum. Of course, the posterior septum resection started 2.5 centimeters below the aortic valve to avoid injury on the branch of this, and this posterior septum resection is connected to the previous anterior resection, and also this resection is planned, of course, by magnetic resonance before the operation. And then we dedicate half of the time of the operation to have a mitral valve repair. In all patients now we utilize a secondary chordal cutting to help the mitral valve to go posteriorly and papillary mobilization. This combined action with these two can treat the majority of the patients, but sometimes we need to associate some other procedure. So in the literature, we have two classifications. One is mitral valve regurgitation due to SEM. Another one is organic mitral valve regurgitation. But I think that during time with the SEM, we have a lot of change in the mitral valve structure, particularly in the ventricular surface of the mitral valve. This is the reason that we prefer to do the mitral reconstruction through the aortic valve, because all the lesions are in the ventricular surface. So for us, it's better to go exactly in the ventricular surface, because if you open the left atrium, you find a normal mitral valve. But if you see the mitral valve through the aortic valve, you have a lot of malformation, like today was a complete distorted mitral valve. Okay, we published 2 years ago a paper about cutting transaortic cutting of the secondary chord. You see secondary chord are attached in the body of the ventricle of the anterior leaflet, and then are individualized. At that moment, if we found a retract cord, the cord were cut and divided from at the beginning from the papillary muscle, and then in the mitral leaflet. So this procedure, before this procedure, we use a transaortic analysis of the anterior leaflet of the mitral valve, and particularly the relationship with the septum and with the fibrosis of the septum. In fact, when we perform a mitral valve repair for degenerative disease, the only goal is to don't have mitral valve regurgitation. But in this field, we have two goals. One, eliminate the mitral valve regurgitation, but also eliminate the gradient. And the gradient comes from the combined action of operation in the septum and the mitral valve. Next. Next. So you can see here the transaortic chordal cutting. You see that we individualize muscularized secondary order chordal cutting. We check the presence in front of this cord of the primary cord, and then we cut the secondary cord, and often together with fibrosis, consequent fibrosis due to traction. Today was very, very evident, this kind of fibrosis. You see the pre on the left and post-operative movie of correction after chordal cutting. You see that systolic anterior motion is eliminated after surgery with this combined action of the myectomy and chordal cut. You see on the right, post-operative, that mitral valve is moving posteriorly and enlarging the outflow tract. And also, if you use color, you see that the mitral regurgitation is eliminated. You see also the posterior myectomy. Next. Okay, next. So, in this slide, another procedure that we associate in all cases is the mobilization of the papillary muscle. This is due for two reasons. You see, in all patients, we see that the head of papillary muscle is looking at the basis of the mitral valve. It's not in the center of the mitral valve. So we dissect free the two papillary muscle. You see on the right how central is the papillary muscle. The second reason, and we see after the rotation of the mitral valve, the anterior commissure usually is rotated below the aortic valve toward the septum. Next. And this mobilization papillary muscle can help to derotate the valve from the septum. So in many patients, we add some more technique to try to complete the mitral valve repair. The majority we are using the Jakub technique to remove the fibrous tissue that sometimes fix the commissure, particularly the anterior commissure into the septum. And now we are using in patient with excess tissue of anterior leaflet in around 50% of the patient, application of the anterior leaflet. In minority of the patient, we applicate the excess tissue. Sometimes we found a systolic anterior motion due to the posterior leaflet, and we applicate the posterior leaflet also with this technique. So you see here again the combined action of the Jakub technique to detach the commissure and the dissection of the papillary muscle, the cutting of second order chord, the rotation on the left preoperative, you have the commissure exactly at the level of the septum attached with the fibrotic tissue, and you see the scripta as a reference point, and you see here double click that the commissure rotate around 20 degrees. So now you see this transesophageal, so you have the anterior commissure in below. So you see that the outflow tract is enlarged, due also to anterior and posterior myectomy. Again, you see another case. It's working?
No.
No? Okay. Same effect, rotation and fixed fibrosis of the anterior commissure, and after the operation you have a less important, you enlarge with the posterior myectomy, anterior myectomy part of the outflow tract, and the commissure is displaced more posteriorly. So the other technique that we associate in around 15–20% of the patient is in many patients we found excess tissue of the mitral valve with an important, sometimes with prolapsing tissues. These tissues very thin and have the chorda sometimes elongated, sometimes broken chorda at that level. So in this case, we applicate with this technique. This technique was described by colleague from Japan, but they cut all this excess tissue. In our experience, we prefer applicate usually with 3 stitches, and sometimes to correct the extra length of one of the 2 elongated cornea. So here you can see preoperative and postoperative finish. You can see the preoperative and postoperative patient who receive preoperative, you receive application of the anterior leaflet. You see in this part the extra tissue preoperative, and then you see the stitch in the free margin A2 of the anterior leaflet with the concomitant anterior myectomy. You relieve the outflow gradient. You relieve also the mitral incompetence, obtain a very good result in this case. Next. Here you have anterior posterior. You see on the left preoperative you have a posterior leaflet SEM, very elongated both leaflet. So we were obliged to duplicate both leaflet. You see the two stitches here, one in the anterior, other one of the posterior. Now there is no evident extra length, and I think we have also the result of the mitral incompetence. Okay, so we have the occasion to review our result from July to April 2017 recently. So we have the cohort is 262 patients, and we have 2 hospital deaths, 0.7%, and 2 deaths during follow-up. 5% of the patients receive mitral valve replacement during surgery. Our philosophy is to try to save the valve in all patients. Just one case was complete calcified valve, so we perform at the beginning mitral valve replacement. In the other patient, we try to save the valve. In 5% of the patient, we have to perform a second cardiopulmonary bypass and put a prosthesis. After surgery, just one patient class 3-4, and our gradient is 9. We have only one patient with mitral valve reconstruction with mitral valve regurgitation more than 3. So I would probably just to say this is a very interesting another case. If you see the preoperative echo, this double leaflet, so in the right you can see it's not a mitral valve, but is extra tissue attached to secondary cord. So was just cutting the secondary cord and the fibrosis, this extra tissue. That this I think is the result you see. Preoperative, the extra tissue, and postoperative cutting this piece of fibrosis that was participating the obstruction. You see on the right the final result in terms of outflow and mitral regurgitation. So I think we go to the magnetic resonance. All the patients go. Ancora. Okay. We control all the patients after 3 months with the transthoracic echo. You see one of the patients is reducing. In this patient, the coaptation, the mitral valve is improved and no incompetence. Next. But just to show no incompetence after 3 months, just to show the result of pre and post, all the patients receive postoperative. We are studying on this magnetic resonance. Move also this one. and you see the difference between the geometric and pathophysiological difference of these two magnetic resonance before and after, and you can appreciate that the mitral valve with the secondary order chordal cutting is moving posterior and eliminating, as in the majority of the patient, the mitral valve incompetence. So let me conclude that the gradient, the obstructions is a complex interaction. One patient is different each other. Another important factor is that it's not so easy to do diagnosis of retraction of said coronary cord by magnetic resonance, also by transesophageal echo. So many times you find some very bad valve like this morning. So our approach is totally from the aortic valve to try to correct the valve, and we proceed this approach by careful valve analysis, are the same valve analysis that we perform through the atrio in degenerative disease. So we hope that in the future the transaortic mitral chordal cutting and the papillary muscle mobilization, we were able to demonstrate that move the mitral valve posteriorly can enlarge the outflow tract and also contribute to improve the long-term result. Thank you very much. You want to conclude? I don't know if there is some connected people in Novara or in Chisinau that want to ask a question.
No. Is there someone in the...
No people are there? So I think that if there is no question, do you have a question, Konstantin?
No. Thank you.
I think it was hard, 2-3 hours, we are 1 hour late, so we close the conference.
I just make a comment to thank you all for your presence, to thank you again, and Professor Spirito, and for your collaboration and for your help. And thanks the Ukrainian team. I think the secret of progress is the collaboration. And I think more we collaborate, more we progress. So thank you, and hoping for future collaboration. And thank you all for being present. Have a good evening. Thank you.